Hi, my name is Ken Brandt. This is my wife Jeannie Brandt. We live in South Tampa with our 3-year-old dog Cooper. Normally just a happy-go-lucky family. And a little bit of my situation. In 2011, I was diagnosed with stage 2 colon cancer, which was possibly due to me not going to doctors enough to get it early. But anyway, I had surgery on that. They were able to get it all, and I never had any chemo or radiation or anything simply because stage 2, it didn't call for that, I was told by my oncologist. I went to the oncologist every 6 months for the last 5 years, and all the blood work always came back fine. This last time in December, some CEA levels, the doctors will know what that is, were higher than normal, and so I went back for a repeat test, and they were still higher. And at that point, he told me he wanted to give me a CAT scan, which I had, and it showed some tumors on the liver, which to me was shocking because I didn't have any symptoms, felt fine, doing my normal bike riding, walking every morning, just my normal life. So I almost felt they had the wrong blood work, and I questioned it. But then he had told me that he was a member of a board or a council that Dr. Sokolich is on that was liver specialist in this type of area, and he talked to the doctor and see if he would consider taking my case. And I found out that he would. At first, we thought it was maybe going to be just a normal, well, if it can be normal, liver resection, just part of the liver, not a huge deal. And I think even my MRI didn't really maybe show the extent of the stage of the cancer. I had looked on the internet at the time, and it said things like, if it's in your liver, it's stage 4, which scared me and shocked me because I had no idea, not being a medical person, but it didn't sound good. Once we got into the surgery part, apparently it was too far advanced to do the normal resection, and so we had this special operation that the doctors will describe, but that's basically my medical history. I've recovered very well from the surgery. I've got quite an incision, as you can well imagine, since it was cut twice in the same spot, but I get up and walk and drive now and do my normal life. So that's basically my beginning.
When did you have the surgery?
I had the surgery on February 28th. I was told at the time, I don't think that my oncologist realized how aggressive it was, because I even went out to Texas and visited my father in January, and he kind of acted like, well, there's not really any super hurry to get this done. But I think probably there really was more than what we realize now.
Thank you, Mr. Brandt.
Yes.
Good morning, Tampa Bay. My name is Alsina. I'm Surgical Director of Liver Transplantation at Tampa General Hospital. We're here with the liver team from TGH, the most specialized group of liver specialists in the west coast of Florida. And we provide care for people that have the simplest liver conditions to the most complex, including those that have cancer, those that have organ damage beyond repair, and sometimes patients whose livers are failing acutely. So our expertise is in hepatic surgery, transplants. We have a group of physicians that are not here, which is the medical side, the hepatologists with incredible support, specialized nurse practitioners, and training of new physicians and research. We have here today Dr. Franco at the end of the table, a hepatobiliary transplant surgeon, and Dr. Sokolich. We will give a short presentation about the case shortly. We have accomplished a few things that we wanted to bring to our attention since we're here. We might as well talk about what's been happening in the last year. The medical division hepatology came together with incredible support and growth. That's new in the west coast of Florida. We have specialized clinics in hepatitis C and fatty liver disease, the specialized clinics in liver cancer, and the program has been now existing for about 5-6 years. That has incredible growth. Liver cancer is the second most common tumor diagnosed at this hospital every year. The program has enhanced our long-term outcomes over baseline statistics that we see in different registries. Most recently, we had participated in 2 pivotal research trials on chemotherapy. Our group participated in those trials, and one particular drug from Bayer called regorafenib, and the trial was called the Resource Trial, obtained FDA approval 3 weeks ago. So this particular drug is a second-line agent and is able to prolong survival in patients that had the standard chemotherapy. And it is important because there are only 2 drugs approved now, and it's been 10 years since any drug had been approved in liver cancer ever. So we're excited about that. There's more developments in oncology that we're waiting to hear from. So in summary, the community needs to know that we're here to help you when sometimes there may not be hope. The transplant program is the last thing that we haven't talked about. It's really unrivaled in this part of the state. We have performed 1,600 transplants over two decades of operation. The program also can claim that it has had continuous surgical leadership for 20 years, uninterrupted ever, and no other program can really claim that in the state of Florida right now. So Dr. Sokolich will lead now the case and more explanation about the hepatic side of surgery, non-transplant in this particular case. Dr. Sokolich.
Good morning with everybody. My name is Julio Sokolich. I'm one of the transplants and hepatobiliary surgeons here at Tampa General Hospital. This morning I would like to share with all of you an operation that we have done on Mr. Brandt, who is present on the table. I call this surgery extreme liver surgery. The reason behind is this is an operation when basically there is no hope for other interventions. It's an operation is not done very often in the country or in the world. This operation was started around 2011, and there is more or less 500 operations done in the world since then. The reasons behind why this operation is not done very often is requires high level of skills for surgery, and also the follow-up is very intense, and there is increased chances for potential complications compared to regular conventional liver surgery. So as Mr. Brandt explained before, he's 67 years old. He was diagnosed with colon cancer in 2011. 5 years later, he was diagnosed with cancer inside his liver coming from the bowel. And nowadays, we are seeing more patients with liver cancers. And most of the time, there is no symptoms that they developed. And as Mr. Brandt mentioned, he was doing really well, and he was kind of shocked when somebody told him that he had cancer in his liver. So at this point, he was referred to our centers for an evaluation. So this is kind of the initial imaging that we had on Mr. Brandt. Here I'm going to point, this is the liver. The liver is the biggest organ that we have in the abdominal cavity. As we see here, is on his case, it was invaded with cancer in multiple areas. This is cancer. This is another area of cancer. This is another area of cancer. This is another area of cancer. And this is another area of cancer. So with these kind of situations, we offer surgery to him. Here at Tampa General Hospital, we are a very dedicated hospital and a very dedicated and skilled team. We evaluate any kind of liver pathology in our service. And in this case, in the operating room, we noticed just 2 weeks from the first, from this CT scan, that this cancer was getting more aggressive. In the operating room, we noticed that these cancer's areas were bigger. So by doing conventional surgery, we will not be able to keep him alive because the operation will require to remove 85% of his liver. And normally, when we do conventional liver surgery, we can resect up to 75, sometimes 80% of the liver in order for the person to survive. So at this point, we had to make a really hard decision with Mrs. Brandt in the waiting area. And the decision was to perform this very unusual operation. As I mentioned to you, is done basically as the only way to get hope when there is no other treatments for this kind of cancer pathology in the liver. The name of this operation is called an associated liver partition and stage hepatectomy. This is a relatively new surgical technique that started to be in practice since 2011. There are not too many centers in the country performing these operations. There is a report about 500 cases done in the world since 2011. So the principle of this operation is when we see an area of the liver that is infiltrated, is seeded with cancer, the idea of the operation is split the liver in two pieces. The area without cancer, that is small, and the area that is big and has full of cancer cells. At the same time, in the first operations, we divide the portal vein, the portal vein going to the tumor area. By doing that, the idea is that all the nutrients, they go into the left portal vein and make these sides of the liver bigger. And the growth of this left side is quicker, but requires a lot of tedious and very meticulous follow-up in order to get to the second stage of these operations. And the growth of this left side of the liver is accomplished sometimes between 7 to 14 days, what is really fast, especially when we are seeing these aggressive cancers. There is other procedures that can be done. It's called portal vein embolizations, but require sometimes 6 to 8 weeks. And when you have an aggressive cancer, there is a chance in 6-8 weeks the cancer has spread somewhere else. So we performed the first stage of this operation, Mr. Brandt. He did really well after the first operations. There was no complications on him. And over time, we evaluate the size of the remnant liver. Remnant liver is the liver that is clear of cancer. And we can see the growth of the liver. On Mr. Brandt, this left side of the liver initially was 16% of the total size of his liver. By doing this conventional surgery, he will not be able to survive. But by doing this very difficult and very unusual operation, done for the first time here at Tampa General Hospital, we were able to make this liver growth from 16% to 26%. In terms of volumes, we are talking about 180 cc's to almost 580 cc's in just 14 days. And with this size of liver, we were able to finish the second operation, remove the area of the liver that was full of cancer. In the pathology of this area, we noticed that the cancer cells were more aggressive than expected, but we were able to accomplish negative margins. What that means, in other words, we have been able to remove all the cancer out of his body successfully. So this is an imaging before we finish the operations. You can see the two pieces of liver splitted. This is the left side that is clean of cancer, and this is the right side that is full of cancer. This is another way to see the same imaging. You can see the liver split it in two pieces, the left side clear of cancer and the right side with the tumor. This is a PET scan. A PET scan is a scanning that we do in order to evaluate the entire body, be sure that there is no remnant cancer cells. And this is 7 weeks from the first operation. And here we have been able to see that there is no cancer cells on him, there is no tumors on his body, and we can see the size of this left side of the liver. Just to compare, this is before surgery. This is the area that with this operation we have been able to make growth from this 16%. We wait until it was 26%, and right now we are talking that is almost 45% of the normal size of the liver. So with this kind of situations, we change a situation where there was no hope into an area that he's going to do well, he's going to be, his survival is not going to be affected, and he's basically cancer-free at this point. So this is a situation we would like to share with all of you for the community to be aware. The epidemiology of liver cancer is increasing. Most of the time it's a silent disease. Here at Tampa General Hospital, we have all the resources. We have all the teams available in order to do the workup for these cases. We perform, as Dr. Alsina has mentioned, we perform from the most simplest operations in the liver or in the pancreas to the most complex operations that not many centers perform in the country or in the world. And also, we perform transplantations for many medical problems that the patients require. So this is kind of the overview of these presentations, and open for any kind of questions if available.
So does this only work for people, what if you had cancer in the entire liver, like it wasn't half and half? Is this wouldn't work in that case?
No, there is situations, if we see that the left side of the liver is involved with cancer, sometimes we can do what is called metastectomy during the first operations. So this operation is created for those kind of difficult cases where there is no other hope. So what we do initially in the first operations, when we split the liver, we remove the cancer areas on the left side of the liver. And then we wait for that left side to get bigger, and then we go back and finish the operations. So it's a very difficult operation, but that's what we can offer to the community here at Tampa General Hospital.
And will his liver eventually reach 100%? Will it regenerate all the way?
Normally, it's going to be probably close to 70–80% of the normal size, but that's going to be more than enough for Mr. Brandt to go with his normal life without problems.
So it was split, but it was still somewhat connected?
Correct. So basically what we have done in the operation is separate the area with cancer and away from the area without cancer. And we kind of cut the blood flow to the cancer cells. So all the nutrients, they go to the healthy liver. And that's how the liver gets bigger faster, and sometimes in 7 to 14 days.
Well, what was keeping them somewhat connected, the two sides?
It's just the hepatic veins, the hepatic artery, and the bile duct. That's the only connections between the two sides.
You said somebody can survive up to with 80% of the liver missing and get 86. So what?
So in theory, we can resect 80% of the liver and the person can live with 20%, but you increases your chances for post-hepatic liver failure. So, and when liver failure happens, unfortunately, sometimes it's irreversible. What that means by that the person is not going to survive potential liver failure. So normally we go around 70% of maximum area of the liver that we can resect safely. So with this technique, we increase the chances or the hope for this population that normally will be kind of like sent to hospice or to areas where there is nothing else that we can do. But in this case, we are opening the door for these situations.
So once the other side, the good side, is big enough, that's when you remove the cancerous?
Correct. And then we increase the chances for successful. And in these kind of cases also, this is our department is transplantation and hepatobiliary surgery. Probably some of you are thinking why we don't offer a liver transplant in these kind of situations and get the problem off. Liver transplantation is offered for certain cancers, not for every cancer. In this case, the cancer that Mr. Brandt had, it was not an indication to perform a liver transplant because the outcomes by doing that operation will be worse. So that's the reason by doing these complex operations, we have accomplished getting him off cancer.
Could you explain that more? What would have, by worse, what would have happened if you had performed the liver transplant?
So when you perform liver transplants for certain cancers, the cancer recurrence is higher when the person is in immunosuppressions to prevent rejections. And the outcomes and the overall survival is not good. Right now, there is well-documented data in terms of liver transplantations for some specific cancers, like hepatocellular carcinoma, that nowadays is increasing secondary to viral hepatitis, or also to other metabolic disorders. We are seeing that more often. So that's kind of one of the indications for a potential liver transplant when resection is not an option.
And you made this decision in the waiting room?
Yeah.
Can you
No.
clarify that?
So when we evaluate this case with Mr. Brandt and Ms. Brandt, we went to the operating room with two plans. Plan A, it was to do a conventional liver surgery, and Plan B, it was to perform these complex operations. In the operating room, we perform an intraoperative sonogram of the liver to evaluate the magnitude of the cancer. So when we evaluate these situations, I scrubbed out and I went to the waiting room to talk to Ms. Brandt and tell her the situation, that conventional liver surgery is not going to help us. We had two options at that time. One, it was to perform this complex operation or close him up, and we knew that his survival will not be great because the cancer was getting very aggressive, and probably his lifespan will be no more than 8 months. So that's the decision we made, and that's how we work here at Tampa General Hospital. This is a teamwork, not just from the physician's part, but we involve the patient's family and the patient's decisions as part of the plan.
What is the risk of recurrence if they did have metastases to the portion of the liver that you're regenerating, and then if they did not? And then what is his follow-up care?
So the chances of recurrence, they are around 10%. So in 10% of the cases, you cannot finish these operations because there is a chance that cancer cells can appear in the normal part of the liver. And in terms of follow-up on him is, we did PET scan that shows that there is no cancer anywhere else in his body. He's going to need chemotherapy, and the chemotherapy that he's going to need is not the full dose chemotherapy, is a reduced dose just for prevention, to avoid any kind of potential recurrence of cancer on him.
What's the risk of hepatic failure?
The risk of hepatic failure with these operations, or if you remove around 75% of the liver, the chances for liver failure, sometimes they are around 30 to 40%. And when liver failure happens, sometimes it's irreversible because there is what we call a multi-organ failure, and then from that situations, the person doesn't survive. So with this operation, the chances for liver failure, they are around 10 to 15% by doing the first operations and waiting for the second operation. That's the reason these operations is only done in very high-level hospitals, and is not done very often because of the complexity.
What was the time in between the first and second surgery?
On Mr. Brandt, it was 14 days. And his total length of stay on Mr. Brandt in the hospital from the first operation to the finish of the operations was 24 days? 23
It
days.
was 5 weeks.
Well,
5
it was
weeks.
just about 4.5 weeks. I think
4.5
it was.
weeks.
Can we talk to Ms. Brandt just about what it was like for them to come out and say, we're gonna have to do this other, extreme portion? I mean, what goes through your head?
Well, it was obviously very stressful, but we had discussed it before he went to surgery, and he said if it came to that, he wanted to go ahead with that. So that obviously helped alleviate the stress of making that decision about his life. But the whole time, Dr. Sokolich and the team kept us so informed about everything, what to expect, that, we got through it as a team, and it was, it wasn't easy, but I don't think any major surgery is probably easy. And now, I mean, he was up walking within a day or two, and he's continued that. So follow the doctor's orders, and it worked out well for us, and we would like other people to know about it.
It was surreal to me because in my own mind, I never ever thought I wouldn't survive, even though Dr. Sokolich would tell us, it's day to day right now, and we're praying for it and working on it. It never really got in my head that I wouldn't make it. I just never really entered my mind until later on, when then I kind of looked back and realized how major this really had turned out to be. I didn't really, during the thing, I didn't really realize, I guess, how major it was. Later on, yes, but, and of course, Jeannie was a great support team. She was there every time I'd wake up in the hospital bed. She's there, and
Get up and walk.
Get up and walk. She was a task driver. Drink my protein drinks. And but we felt part of a team with this group here, and it was made it much easier to go through.
And stepping back and looking at, this was the first time these guys did this, and you were such a, extreme case. Is that also surreal to know that, you made it through and you look great?
Yeah, I guess everybody kept coming in the room and saying, "You look fantastic," and I'd be laying there. I don't feel so fantastic, but everybody said, "Oh, your color's good and you're looking great," and they tell me that, and I guess I believed them, but it was a long time to be in the hospital, and I think at some point we just had to go home because we're worried about infection at that point, which luckily we never got anything, but I don't know. Like I say, it was a start to finish. It just never really entered my mind that I wouldn't survive. I just kind of felt that, okay, this is major, but I'm for sure going to make it.
Everybody good? All right, thank you all for coming out. Thank you for being here. And they'll be available afterwards if you have any other follow-up questions.